In this section, we're going to be thinking about disorders of the endocrine system. Hormones are chemical messengers which are carried from their source through the blood to all parts of the body. The glands which produce them are known as endocrine glands. There are some other chemical messengers besides hormones which modulate body processes. The functions of the endocrine system are closely linked to those of the nervous and immune systems. Besides endocrine secretion, there are two other types of secretion. Paracrine secretions are chemicals that act locally. They do not circulate to the entire body as endocrine hormones do, but are released and act on cells and tissues in their immediate surroundings. Some of the most important chemicals with paracrine secretion are prostaglandins and leukotrienes. Autocrine secretions are chemicals that cells synthesize that affect themselves. The main ones are growth factors. Almost every kind of cell produces one or more growth factors which make that cell develop in a normal fashion. There are two other groups of chemicals which also help regulate our body's functioning: vitamins and eicosanoids. Most of our vitamins come from the foods we eat. They act as cofactors and help modify body functions. Do you remember cofactors? There's at least one vitamin that is synthesized by the body. Vitamin D is produced in the skin following exposure to sunlight. While we call it a vitamin, it acts as a hormone. Vitamin A also functions as a hormone. Eicosanoids are derived from phospholipids in cell membranes. Prostaglandins and leukotrienes are important groups of eicosanoids. They are both involved with the inflammatory response. Hormones exert their influence by reacting with receptors. Receptors are complex molecules which are located either on the surface of the target cell or inside the target cell. The receptors are specific for a certain hormone. Typically, there are 2,000 to 10,000 receptors on any given cell. This number varies for a variety of reasons. Hyposecretion of a hormone will usually result in an increase in the number of receptors. This gives our cells more sensitivity to what hormone molecules are present. Hypersecretion of a hormone usually reduces the number of receptors for that hormone. The affinity of a receptor for a specific hormone will be affected by environmental factors, especially pH levels. If the receptor is on the surface, then a second messenger is involved. The hormone is the first messenger. When it attaches to a surface receptor, it produces a change in the receptor, which in turn activates the second messenger inside the cell. This second messenger modifies the cell's activity. Hormones which are lipid-soluble are able to pass through the cell membrane, and thus their receptors are usually inside the cell. The hormone and its receptor often bind to the DNA of the cell and affect its activity. For example, it may cause the production of messenger RNA, which in turn will cause the cell to synthesize a protein. Where receptors are located depends upon the chemical composition of the hormone. If it is lipid-soluble and can enter the cell, the receptors are usually inside the cell. Once the hormone is joined to the receptor, the resulting complex will move to the nucleus where it affects the activity of the cell. It usually activates or suppresses some mechanisms or gene activity. Thyroid hormones, estrogen, and testosterone are some of the lipid-soluble hormones. If the hormone is not lipid-soluble, like insulin, parathyroid hormone, thyroid-stimulating hormone, and antidiuretic hormone, it will attach to the surface receptors. This binding may open ion channels. Ions move into the cell, and they cause a change. Calcium is commonly the ion involved. Or the binding of the hormone to a surface receptor may cause the production or release of another chemical inside the cell. This chemical is known as the second messenger. There are two main mechanisms for regulating the release of hormones. One is the hypothalamic pituitary regulation, and the other is negative feedback. The hypothalamus releases a number of hormones which target the pituitary and control the release of its hormones. They include growth hormone releasing hormone, growth hormone inhibiting hormone, corticotropic hormone, prolactin releasing hormone, and prolactin inhibiting hormone. The pituitary in turn releases hormones that control other glands such as the gonads and the mammary glands. Negative feedback regulates the levels of many hormones that are secreted. It works like a thermostat. For example, if calcium levels drop, parathyroid hormone secretion will increase, and this will raise the level of calcium in our blood. When calcium levels become too high, the parathyroid hormone secretion is reduced, and this brings calcium levels back into the normal range. While negative feedback is by far the more common control mechanism, a few more hormones are controlled by a positive feedback mechanism. Increase in a hormone causes another gland to produce a hormone, which stimulates the first gland, producing the original hormone. In this type of system, it is essential that there is a way of stopping the production of the first hormone. An example of such a mechanism involves the ovarian follicle. Increased production of estrogen during the follicular stage of the menstrual cycle causes increased production of follicle-stimulating hormone, which, in turn, stimulates the follicle to produce more estrogen, which causes the production of more follicle-stimulating hormone, and so it goes. The cycle is broken when the follicle degenerates. The pituitary gland hangs from the hypothalamus on a stalk of tissue called the infundibulum. It rests in the sella turcica, which is part of the sphenoid bone. The pituitary is very vascular and thus vulnerable to ischemia and infarction. The likelihood of infarction is increased during pregnancy when the gland is enlarged and much more vascular. The pituitary is especially susceptible to necrosis because its blood supply to the hypophyseal system is already partially deoxygenated, and during pregnancy, oxygen demands have increased. Hypothalamic hormones are transported to the anterior pituitary through hypophyseal portal vessels. If you remember, a portal system is made up of blood vessels between two capillary beds. Hormones from the hypothalamus are transported to the posterior pituitary through the nerve axons. Oxytocin and antidiuretic hormone are produced by the hypothalamus but released from the posterior pituitary. Hypopituitarism will affect many other glands. There are several causes for this undersecretion by the pituitary gland, the most common of which is tumors. A tumor can replace a normal hormone-secreting tissue, resulting in a reduction in the production of hormones. This process is often very slow, lasting over a period of 10 to 20 years before it is noticeable. A person has to lose about 70 to 90% of the tissue of the pituitary before the effects are obvious. Infarction due to the large loss of blood during childbirth is also another cause of hypopituitarism. Empty sella syndrome occurs when the sella turcica is large and the pituitary gland is smaller than normal or completely absent. This condition is most common in overweight, middle-aged women who have given birth to more than one child. They have symptoms that reflect the loss of pituitary functions, such as the ceasing of menstrual periods, infertility, fatigue, and intolerance to stress and infection. In children, empty sella syndrome may be associated with the early onset of puberty, growth hormone deficiencies, pituitary tumors, or pituitary gland dysfunction. A disorder of the hypothalamus will also have an adverse effect upon the pituitary gland. So things such as tumors and lesions of the hypothalamus, infections, trauma, or radiation exposure to the hypothalamus can cause hypopituitarism. Some of the manifestations of this condition will be weakness, fatigue, loss of appetite, cold intolerance, and loss of sexual function. A condition known as panhypopituitarism is when all hormones are absent. If the pituitary gland stops making hormones, the production stops in this particular order. First to go is growth hormone, then luteinizing hormone, follicle-stimulating hormone, thyroid-stimulating hormone, and ACTH. The mnemonic for this is go, look for the adenoma. The treatment for hypopituitarism very definitely depends upon the cause, and typically hormone replacement therapy is used to counteract whatever is causing the condition. Growth hormone, also called somatotropin, is produced throughout our entire lifespan. It promotes protein synthesis and the use of fats for energy. It targets bones, cartilage, and skeletal muscles. It stimulates the epiphyseal plates, causing growth of long bones, and it stimulates cartilage growth, and especially the growth of bones and length. In addition, it plays a major role in the growth and development of our internal organs. Growth hormone has anti-insulin actions in that it promotes the use of fats and decreases the use of glucose, thus increasing the amount of glucose in our blood. It causes the liver to break down glycogen and release glucose into the blood. The secretion of growth hormone is controlled by two hormones from the hypothalamus: growth hormone releasing hormone and growth hormone inhibiting hormone. Short stature in children may be caused by a variety of mechanisms. Some children inherit a lack of stature from their parents, and others simply do not grow as quickly as other children. This constitutional delay, lack of stature, will usually disappear as the child becomes older. Certain genetic disorders, such as Turner syndrome, will also result in short stature. Retarded intrauterine growth may be the result of circulatory problems between mother and fetus or maternal malnutrition. If a child starts with a very low birth weight, it may take several years for it to catch up and attain normal weight and stature for their age group. There's a whole range of endocrine disorders that can affect a child's stature. One of the main ones is a growth hormone deficiency, which is discussed on the next slide. Others include an underactive thyroid, diabetes, Cushing syndrome, and underactive parathyroid glands. Children who suffer from chronic diseases such as asthma, heart or kidney diseases may be below normal in stature for their age. This may correct itself over time, especially if the chronic condition is corrected or treated successfully. Psychosocial dwarfism is seen in some emotionally deprived children. Children who are neglected or severely disciplined may have poor eating and drinking habits. If family conditions improve, there is often a catch-up spurt of growth. Here we see a picture of fraternal twins. The twin on the left is the pituitary dwarf. The twin on the right is actually a girl. Pituitary dwarfs exhibit normal intelligence but are short in stature. Their bodies are normally in proportion to the length of their legs and the size of their head. They are below the 5th percentile for linear growth. Pituitary dwarfism can be caused by lack of growth hormone releasing hormone from the hypothalamus, by a pituitary tumor, or by the lack of pituitary development. Replacement therapy usually consists of giving growth hormone that has been produced by DNA recombinant techniques. Several doses a week is the usual amount. This can continue into adulthood. Human growth hormone replacement is also used to treat short stature due to other causes such as Turner syndrome or chronic renal insufficiency. There are some ethical considerations about treating children with normal short stature, children whose parents are also extremely short. They formerly used growth hormone extracted from cadavers. However, occurrences of Creutzfeldt-Jakob disease stopped this practice. Like short stature, there's a variety of things that can cause tall stature in children. These include genetics. If both parents are exceptionally tall, it is not surprising if their child is also tall. Genetic abnormalities such as Marfan syndrome and XYY syndrome can also result in extra height. Endocrine disorders such as an excess of growth hormone can also cause extra height. Sometimes when children show great potential for being extra tall, they want to cause the epiphyseal disc to close early. And so they do this by giving treatment with sex hormones. Testosterone is used in boys and estrogen in girls. It typically takes 3 to 4 years for this to have any effect. So if they see a child is going to be extraordinarily tall, they have to start early if they want to get the desired effects. In this picture, we see 22-year-old identical twins. The man on the left is a pituitary giant. The symptoms of giantism are often unrecognized for a long period of time. It is a fairly rare condition because of early detection and treatment. The usual cause for giantism is an adenoma on the pituitary gland. Treatment is usually the surgical removal of the tumor and is curative in about 80% of the cases. For situations in which treatment cannot be completely removed, gonna start that one over. This is a picture of 22-year-old identical twins. As you can tell, the young man on the left is a pituitary giant. Giantism has symptoms that are often unrecognized for a long period of time. Today, giantism is fairly rare because of early detection and treatment. The usual cause is an adenoma on the pituitary gland. Treatment is usually surgical removal of the pituitary tumor, and this is curative in about 80% of the cases. For situations in which surgery cannot completely remove the tumor, medication is the treatment of choice. The most effective medications are somatostatin analogs, which reduce the secretion of growth hormone. When there's an excessive production of growth hormone in adulthood, after the epiphyseal discs have sealed, the bones cannot grow in length, but some of them will grow in diameter. This usually involves the bones of the face and the hands and the feet. Here we see a series of 4 pictures taken over the lifespan of this woman. In the first 2, you can see that she is a normal child and then a rather pretty young adult. But then as the enlargement of the bones in the face and hands grow, you can see that her features become more coarse and changes her appearance drastically. This condition, called acromegaly, is relatively uncommon. Only about 3 to 4 people in a million will develop this annually. It is usually diagnosed in adults 40 to 50 years old, but in most cases the disease has been present several years before diagnosis occurs. It is most often caused by a growth hormone secreting pituitary tumor. Some of the characteristics of the people who suffer from acromegaly are enlarged tongues, interstitial edema, an increase in size and function of sebaceous and sweat glands, coarse skin and body hair, weight gain, muscle weakness, and fatigue. The teeth become splayed, making chewing difficult. The larynx enlarges, which lowers the voice. The internal organs will also become enlarged. Often a person with acromegaly will develop diabetes mellitus because the beta cells of the pancreas are overstimulated. Growth hormone causes reduced uptake of glucose and increased insulin secretion. Sleep apnea is very common for people who have acromegaly because of an increase of soft tissue in the pharynx. The surgical removal of the growth hormone secreting tumor or medication which inhibits the secretion of growth hormone is the normal treatment. Growth hormone receptor analogs bind to growth hormone receptors and prevent growth hormone from binding to them. The thyroid gland is located on the anterior surface of the trachea, just below the larynx. Much of the tissue is made up of sac-like structures called follicles. These follicles produce 2 hormones from iodinated thyroglobulin. This is the colloid in the follicles. It is secreted by the follicular cells. Thyroglobulin is a glucoprotein iodine complex, which in turn is changed into 2 hormones, T3 and T4. 90% of the hormone produced is T4, also known as thyroxine. The other 10% is T3, or triiodothyronine. The levels of thyroid hormones are regulated by a negative feedback system, which involves the hypothalamus and the anterior pituitary. In addition to the follicle cells, parafollicular cells between the follicles produce calcitonin, which regulates the levels of calcium in the blood. It increases calcium levels in the blood. And it does this by breaking down bone tissue, increasing absorption of calcium in the intestines, and reducing the excretion of calcium in the urine. Thyroxine increases the metabolism of many of our tissues. It also increases the body's usage of lipids, vitamins, proteins, and glucose. Hyperthyroidism will cause breakdown of muscle proteins and cholesterol. Blood cholesterol levels will be lowered. Thyroxine increases glucose absorption in the small intestine. It is necessary for the growth and development of children, especially for the brain and nervous system. It also is necessary for the normal development of sexual functions. A second hormone produced by the thyroid is calcitonin. Calcitonin decreases blood calcium levels by stimulating the formation of bone tissue. Congenital hypothyroidism is quite rare. It occurs in only about 1 in 5,000 infants. It may be due to a lack of thyroid tissue or to a deficit of thyroid-stimulating hormone. However, when it does occur, it will cause preventable mental retardation. Once the damage is done, it is not reversible. The testing of neonates is required in many states. A drop of blood is taken from the child's heel and tested. The tests for the lack of thyroid tissue is high levels of thyroid-stimulating hormone in the blood and a lack of thyroxine. Treatment is by replacement thyroxine. This treatment needs to be done early because mental retardation will start to occur as soon as at 6 months of age. Half of brain development and growth occurs during the first 6 months after birth, so it is very important that we have early treatment for this condition. Mental retardation and growth impairment will occur if it is not corrected. Cretinism is the name for the condition that develops if there's untreated hypothyroidism. All 4 people shown in this picture are the same age. The 3 in the front suffer from cretinism. The 3 in the front are actually all females. Notice their lack of secondary sex characteristics. Acquired hypothyroidism is the most common disorder of thyroid function. It is most common in women. Some of the clinical manifestations are a sluggish feeling, fatigue, cold intolerance, a low basal metabolic rate, bradycardia, and impaired memory. It can be due either to destruction of the thyroid tissue or dysfunction of the thyroid tissue. One of the most common causes of hypothyroidism is loss of thyroid tissue after radiation treatment for hyperthyroidism or ingestions of large amounts of iodine. Hashimoto's disease is an autoimmune disease in which the thyroid tissue may be completely destroyed. It is also caused by pituitary dysfunction as a result of the dysfunction of the hypothalamus. Hypothyroidism can lead to myxodemus coma, which is a condition that is most common in elderly women who have an underactive thyroid. Cold seems to be a precipitating factor for this condition, and it seems to be more common in women in winter. People who suffer from this condition will often be exhibiting hypoxia, retaining carbon dioxide. They'll have fluid imbalances, and it can lead to a coma, hypothermia, and cardiovascular collapse. Treatment for myxodemus coma is eliminating these different contributing factors. One of the most common causes of hyperthyroidism is Graves' disease. Graves' disease is an autoimmune condition that is more common in women than in men. It occurs in less than 1/4 of 1% of the population. During Graves' disease, antibodies stimulate the thyroid gland to oversecrete. Graves' disease is most commonly diagnosed among people from 20 to 40 years of age, but it can also occur in children and adolescents. Usually with Graves' disease, there is the development of a goiter. Sometimes it is associated with other autoimmune diseases such as pernicious anemia and myasthenia gravis. Ophthalmopathy occurs in about 1/3 of the cases, which can cause visual loss with damage to the optic nerve. There are several clinical manifestations of Graves' disease. They include irritability, restlessness, tachycardia, heat intolerance, amenorrhea, impotence. Many times fibroblasts behind the eye will enlarge, forcing the eyes out, giving them a very prominent protruding effect. Sometimes this condition is reversible, sometimes it is not. Treatment for Graves' disease either involves the use of radioactive iodine, which destroys part or all of the thyroid gland, or drug therapy, which suppresses the thyroid gland. In almost all cases of having destruction by using radioactive iodine, lifetime replacement of the thyroid hormone must be taken. Thyroid cancer is the most common endocrine malignancy. One of the main risk factors for thyroid cancer is exposed to iodine radiation. Often, when children have been treated for another form of cancer, they later will develop thyroid cancer. The treatment is usually a total thyroidectomy and post-operative radioactive iodine, trying to destroy all of the thyroid tissue. Survival rate is better than 95%. The adrenal glands are located on the top of the kidneys. They consist of two types of tissue. The inner layer, the adrenal medulla, produces epinephrine and norepinephrine. These two chemicals are also produced by the nervous system, so life will continue without the functioning of the adrenal medulla. The adrenal cortex is another story. It produces over 30 different hormones, all of which are steroids. The adrenal cortex is made up of 3 separate kinds of tissue, and the 3 main hormones produced are aldosterone, cortisol, and androgens. Cortisol, or cortisone as it's sometimes known, helps the body respond to stress and change. It is produced in the zona fasciculata. Cortisol mobilizes nutrients, controls the amount of water in the body, and stimulates a rise in blood glucose. Cushing's syndrome is hypercortisolism due to hyperfunction of the adrenal cortex. Cushing's syndrome is 3 times more common in women than in men. There are 3 common causes of Cushing's. 1. The excessive secretion of ACTH by the anterior pituitary. This is often caused by tumors on the pituitary gland. A person can also get these same symptoms by taking cortisone. A second cause is an adrenal tumor, and a third cause is a non-pituitary ACTH secreting tumor. Cushing's syndrome can be fatal if it's untreated. Typically, treatment is either using surgery and removing the mass or radiation and destroying the mass. Most adrenal tumors are benign. If the tumor is malignant, it is usually a small cell carcinoma. Primary adrenal carcinoma is quite rare, but it is a common site for metastasizing cancers from the breast, stomach, pancreas, kidneys, and colon. So surgical removal is usually recommended for any mass on the adrenal glands that measures more than 4 centimeters across. Here are some of the manifestations of Cushing's syndrome or disease: weight gain, fat deposition in trunk, face, and cervical areas, a buffalo hump between their shoulders. About 20% of the people with one of these conditions will develop diabetes mellitus because of cortisol-induced glucose resistance. Women who have Cushing's also have an increase in facial hair and acne. There will be muscle wasting due to protein breakdown, and a person with Cushing's usually has very thin limbs. Osteoporosis often develops due to the lack of protein framework in bone and changes in calcium metabolism. 50% of the people with the syndrome experience alteration in mental status, suffering from irritability and depression, as well as things as severe as schizophrenia. Addison's disease, also known as primary adrenal insufficiency, occurs when the adrenal gland is not producing sufficient cortisol. In about 80% of the cases, Addison's disease is caused by the autoimmune destruction of the adrenal cortex. This is sort of a gradual onset. It's usually not a problem until about 90% of the adrenal gland is destroyed. Some of the common symptoms of Addison's disease are chronic worsening fatigue, muscle weakness, loss of appetite, and weight loss. Darkening of the skin, known as hyperpigmentation, often occurs, especially on scars, skin fold, and pressure points. Symptoms are often ignored as onset is gradual. Stressful events like another disease or an accident may make symptoms worse. Sudden worsening of symptoms is called an adrenal crisis. Then a person may have sudden penetrating pain in the lower back, abdomen, or legs, severe vomiting and diarrhea, dehydration, low blood pressure, loss of consciousness. Addison's disease can be fatal if untreated. Before 1950, tuberculosis was the most common cause of Addison's disease in the United States and Canada. It still is a major cause elsewhere in the world, but since tuberculosis is pretty much under control in the United States and Canada, now the most common cause is adrenal insufficiency. And most times this has an autoimmune basis. Since cortisol production naturally increases in an emergency situation, persons with adrenal insufficiency should always carry identification stating their condition in case of an emergency. A card or medical alert tag should notify emergency healthcare providers of the need to inject cortisol if the person is found severely injured or unable to answer questions. The pancreas is made up of two major tissue types: acinar cells, which produce digestive enzymes and bicarbonate ions, and the islets of Langerhans, which are endocrine cells. Within the islets of Langerhans, there are three different types of cells, each producing hormones. Alpha cells produce glucagon, beta cells secrete insulin, and delta cells secrete somatostatin. Insulin and glucagon act in opposition to each other. Insulin lowers blood glucose, and glucagon raises it by causing the liver to break down glycogen and release glucose into the blood. Somatostatin inhibits the secretion of insulin and glucagon. It also reduces gastrointestinal activity after eating. This gives food more time to be absorbed. Insulin is the only hormone known to directly lower blood glucose levels. It does this three ways. It promotes glucose uptake by target cells and provides for glucose storage as glycogen. It prevents fat and glycogen breakdown, and it inhibits gluconeogenesis and increases protein synthesis. Insulin also promotes fat storage by increasing the transport of glucose into fat cells, where it is converted into triglycerides. It inhibits the making of glucose from other sources, such as amino acids. It inhibits the breakdown of glycogen. Insulin is needed for the normal growth and development of children and adolescents. Insulin secretion is stimulated by high concentrations of glucose. Blood glucose enters beta cells and is metabolized to form ATP. This ATP closes the potassium channels in the cell membrane and depolarizes the membrane. This opens calcium channels and causes insulin secretion. Because cell membranes are impermeable to glucose, it's necessary that they have a glucose transporter that helps get the glucose molecule through the cell membrane. These transporters are protein molecules that are embedded in the cell membrane. They have been named GLUT1, GLUT2, and so forth. GLUT1 transporters are found on the cell membranes of all tissues, but it is especially important in moving glucose into the nervous tissue. The GLUT2 transporter has a very low affinity from glucose. It only acts as a transporter when the blood glucose levels are high. The GLUT2 transporter is found on liver cells and beta cells. GLUT4 transporter is insulin dependent. It's found on the inside of the membranes of skeletal muscle and adipose tissue, and it only begins to function after a signal from insulin. The GLUT4 transporter needs a signal from insulin to function. Once insulin binds to the receptors on the cell membrane, it increases the transport of glucose through the cell membrane. It also causes the release of signaling proteins that affect the metabolism of proteins, fats, and glucose. GLUT4 transporters, remember, are found on the cell membranes of adipose tissue and skeletal muscle. Glucagon is a catabolic hormone released by the alpha cells in the pancreas. The secretion of glucagon is regulated by blood glucose levels. Once it's released, it goes through the portal vein from the pancreas to the liver. In the liver, it targets the hepatocytes and causes the breakdown of glycogen. This will very quickly raise blood glucose levels. Glucagon also brings amino acids into the liver where they are converted into glucose. This is important because the liver only stores so much glycogen, and this will help keep blood glucose levels up after glycogen might be used up. High levels of glucagon will activate lipase in adipose tissue, which will break down fat. That's important because in the fasting state, the primary source of energy for muscle tissue is fatty acids that are produced by the breakdown of fat. A leading cause of death and disability in the United States, diabetes is a disorder of carbohydrate, protein, and fat metabolism that is caused by a lack of insulin or by a decrease in responsiveness of tissues to insulin. 17 million Americans have been diagnosed with diabetes, and it is more prevalent in African Americans and Hispanics. People who are diabetic find themselves at increased risk for many other diseases, including heart disease, renal disease, blindness, amputation, complications of pregnancy, and stroke. There are two types of diabetes. Type 1 affects about 10% of the individuals who have been diagnosed with diabetes. It is characterized by the destruction of the beta cells of the pancreas. It is most commonly diagnosed in those between the ages of 5 and 15. It is more prevalent in Caucasians than any other race in the United States. With type 1 diabetes, the person makes no insulin. Those who have it exhibit elevated blood glucose because the glucose is unable to get into the cells. When glucose is not entering our cells, they will break down body fats and proteins to produce energy. This means it is very likely that they will develop ketoacidosis if they are not given insulin replacement. Of the 10% of people in the United States and Europe who have type 1 diabetes, 95% of these have autoimmune type 1. This is also called type 1A. That means they inherited a tendency to abnormal autoimmune response that affects beta cells. Antibodies involved in this response may be detected as many as 9 years before diagnosis. Development of this autoimmune type 1A may be rapid, which is more common in children, or it may be slow, which is more common in adults. Either way, it requires the giving of extra insulin. Idiopathic type 1B is very rare. It's an inherited condition where there's no evidence of autoimmune response. It usually occurs in those of African or Asian descent. Today, type 2 diabetes accounts for 90 to 95% of the cases of diabetes. Most of the people with this condition are older and overweight, but type 2 diabetes is being diagnosed in obese children and adolescents in alarming numbers. It is predicted that within the next 10 years, type 2 diabetes will become more common in children than type 1. Two important abnormalities involved with type 2 diabetes are insulin resistance and increased glucose production by the liver. Insulin resistance occurs when the target tissues fail to respond to insulin. This means decreased uptake of glucose by skeletal muscle and a corresponding increase in glucose production by the liver. In addition, there frequently is a decrease in insulin production. This decrease is the result of beta cell dysfunction. Beta cell dysfunction has been linked to an increase in beta cell apoptosis and a decrease in beta cell regeneration. Lipid toxicity is another factor that causes beta cells to fail. It is estimated that beta cell function has been reduced by 50% in most people at the time of their diagnosis with type 2 diabetes. Both genetic and environmental factors play a role in the development of type 2 diabetes. People who have a positive family history for the disease have a much greater chance of developing it. Despite the recognition of this strong pattern of predisposition, the genetics of type 2 diabetes remains a mystery. This is partly due to the difficulty of sorting out the environmental factors that are involved. Obesity and physical activity remain the main culprits in this picture. It is not only the amount of fat a person stores, but also its location that has an effect upon insulin resistance. It has been found that people with upper body or central obesity are at greater risk for developing diabetes than those with lower body or peripheral obesity. Thus, diet and exercise should be aimed at reducing this visceral fat. Visceral fat leads to the chronic elevation of free fatty acids. It has been shown that free fatty acids can have a toxic effect on beta cells and can also cause insulin resistance by inhibiting glucose uptake and glycogen storage. In addition, free fatty acids have been shown to reduce the sensitivity of liver cells to insulin. The result of this is increased production of blood glucose by the liver. An additional consequence of high levels of free fatty acids is the storage of excess fats in non-adipose tissues such as skeletal muscle, the heart, and the pancreas. Normally, adipocytes are the source of several important chemicals which are involved in a wide range of processes, including glucose and lipid metabolism, inflammation, and blood clotting. In obesity and type 2 diabetes, there is a reduction in the production of some of these chemicals, such as adiponectin. Adiponectin, which is secreted by adipocytes and circulates in the blood, is the only known adipocyte-secreted factor which increases insulin sensitivity in cells. It has been shown that decreased levels of adiponectin coincide with insulin resistance and the development of type 2 diabetes. The fact that obesity is a state of adiponectin deficiency makes this hormone a very tempting target for possible therapeutic interventions, focusing on the possibility that adiponectin treatment may improve obesity-related insulin resistance and arteriosclerosis. By promoting glucose uptake, a second function of insulin is that it prevents the liver from breaking down glycogen and releasing the resulting glucose into the blood. When levels of insulin are low, this inhibition is decreased. Hypoglycemia occurs when there is too much insulin in the blood and when blood glucose levels are low. This sometimes happens with people who are taking insulin if they make an error in their dosage, do not eat, or have a high level of physical activity. Alcohol reduces the release of sugar from the liver and can be a contributing factor. Some of the common symptoms of hypoglycemia are headache, difficulty in problem solving, and altered behavior. The person will also have often have a feeling of hunger, anxiety, experience tachycardia, sweating, and have cold, clammy skin. The signs and symptoms vary greatly, and not everyone will experience all of them. This is especially true with children and the elderly. Mental confusion is perhaps the most common symptom in the elderly. The best treatment for hypoglycemia is to give the person sugar or foods high in carbohydrates, but care must be taken not to put them into hyperglycemia. If the person is unconscious, an injection of glucagon may be given. This will stimulate the liver to break down glycogen and release glucose into the blood. Hypoglycemia may occur in people who do not have diabetes. Some of the most common causes are not eating, drinking alcohol, severe heart, kidney, or liver failure, a systemic infection, and sometimes types of weight loss surgery. The lack of thyroxine or cortisol, or a tumor on the pancreas which causes an overproduction of insulin. Treatment depends upon what is causing the hypoglycemia. If it is another illness, correcting that condition may relieve the hypoglycemia. The presence of heart and blood vessel disease is 2 to 4 times more common in those with diabetes. Multiple risk factors for vascular disease, including obesity, hypertension, hyperglycemia, are frequently found in people with diabetes. Often, people who develop type 2 diabetes already have macrovascular disease at the time of their diabetes diagnosis. It is estimated that 50 to 75% of those with type 2 will die of a vascular problem. Management of cardiovascular risk factors is important. It should include the cessation of smoking, control of hypertension, control of diabetes, and lowering of lipid levels. Strokes are more prevalent in those diagnosed with diabetes and associated with poorer outcomes. Diabetes is the leading cause of blindness in the United States. Retinopathy is characterized by abnormal permeability of the retinal capillaries, the formation of microaneurysms, hemorrhage, scarring, and retinal detachment. The risk factors are similar to those with other diabetic pathologies: poor control of blood sugar, high blood pressure, and high levels of lipids in the blood. Because of the high risk, regular dilated eye examinations are important for the diabetic patient. Treatment depends upon the particulars of a patient's condition. Not all of those with diabetes will develop nephropathy. Therefore, it is important to focus on eliminating the risk factors for this complication. They include elevated blood pressure, familial predisposition, poor control of blood sugar levels, smoking, and high blood lipid levels. People who smoke have a much greater risk of developing kidney disease, even if they don't have diabetes. And for people who smoke who have type 2 diabetes, the rate of progression to chronic kidney disease is twice as rapid as for those who do not smoke. Damage to nephron affects 30% of the people with type 1 diabetes and 4 to 20% of those with type 2. The most significant problems involve the glomeruli. Often, damage causes the thickening of the basement membrane of capillaries of the glomeruli, which allows plasma proteins to leave the blood and pass into the urine. This is an early sign of diabetic kidney damage. This loss of proteins can cause edema. Nodules may develop in the glomerular capsules, which may impair circulation with the subsequent loss of kidney function. The best treatment is prevention. Degeneration or loss of nerve fiber results in decreased nerve function. There are 2 types of changes that occur with neuropathic complications. The first is thickening of the walls of blood vessels which supply the nerves. This leads to ischemia, which may play a large role in the development of neural changes. The second is loss of myelin due to damage to Schwann cells. This slows down nerve impulse conduction. Somatic neuropathy involves loss of feeling, touch, and position sensing in the lower extremities. This not only increases the risk of falling, but also increases the risk of injuries to the feet because the person has lost feeling. Painful neuropathy involves the neurons that carry pain impulses. They become hypersensitive to light touch, and often there is a sensation of burning pain that is very disabling. Autonomic neuropathy involves the organs controlled by the autonomic nervous system. This can include gastrointestinal disturbances and dysfunction of bladder and sexual functions. Gestational diabetes is a disorder of glucose intolerance that occurs during pregnancy. It affects 5 to 10% of the pregnancies in the United States. All pregnant women should be assessed for the risk of developing it as soon as they realize they're pregnant. If they are at high risk, then they should be tested at once and tested again between the 24th and 28th week of pregnancy. Some of the risk factors for developing gestational diabetes are obesity, having previous offspring with a birth weight greater than 9 pounds, being over 40 years of age, having a family history of type 2 diabetes, and belonging to a high-risk ethnic group such as African American, Native American, Hispanic, and Asian. Good nutrition is the mainstay of therapy for gestational diabetes. Self-monitoring of blood sugar levels is very important, and if necessary, insulin should be given. If untreated, gestational diabetes can result in metabolic abnormalities for the fetus and stillbirth, or a very large baby weighing more than 9 pounds. Also, neonatal hypoglycemia is a possibility. 97% of the people with gestational diabetes will return to normal glucose tolerance following delivery, but there is an increased risk of developing type 2 diabetes later in life. It is estimated that up to 50% of the women with gestational diabetes will develop type 2 diabetes within 5 to 10 years.